switched around, or they started off with pazopanib and then switched to sunitinib. So each patient had the exposure for both drugs. In that sentence, they really had an understanding which drug was better than the other, and it was double-blinded. So here, whatever is listed in orange is the patient's preference. So after the end of the study, patients have been asked, which drug did you perceive better in a certain way? Let's say for better quality of life, for instance. So whatever is orange was preferred by patients in a double-blinded fashion. For pazopanib, whatever is blue has been the preference for patients for sunitinib. And what makes it really interesting is if you compare that to the outcome that we have done as oncologists based on CTCAE terms. So, for instance, fatigue. Less fatigue for pazopanib. It's quite high, it's striking the difference. So you look at the CTCAE, which is objective in terms of how it has been recorded, and look at this. There's no difference. Okay, so in terms of physicians reporting, there's no difference between those two drugs, but still it makes a big difference for your patient. The same is true for nausea and vomiting. There's a clear preference for patients, but there's no difference in terms of objective AEs. And it's, I think, even more interesting for diarrhea, because here there's just a tiny bit of better preference for pazopanib. But if you look into the objective AEs, it's vice versa. There's more objective AEs in terms of diarrhea with pazopanib than with sunitinib, and still being perceived in a better way by the patients than sunitinib in that scenario. So it really makes you think of, who's the expert actually here? Is it a patient or is it really the physician? And I think that really has fostered a whole debate on how to envision data, and has led to the development of pro-CTCAE, which I think is a very good tool to assess these kind of effects. So in order to give you some flavor, I added some case studies within my talk. So the first one you see here, this is a patient which has been treated in my department, 60 years old, male patient. He had metastatic disease. I mean, there has been a couple of years between the initial presentation, resection of the tumor, and metastatic disease. According to the risk criteria, it's a good risk. Echo performance status is 1, and he appeared to have visceral bone metastatic disease. This is his medical history. So there's some hemiplegia, apoplexy, 2001, arterial hypertension, cataract, and diabetes. So the question would be, what is the ideal first-line candidate? And prior to having said that, I mean, something I would like to share with you is the knowledge that we have that bone metastatic disease is a poor prognostic factor, actually. And that is what makes it also attractive to have, in terms of progression-free survival and overall survival, it's both inferior. And the question would be, what is the most effective treatment for that patient that can be really tolerated? So as we don't have a voting system, I don't know, we just raise hands, I would say. So we just do some little exercise for you, because it's late in the day. So can we have some lights, please? So I can see. So light on, just a little bit of light. So who would vote for BAF interferon in that patient? Is that something that you do? Pazopanib?
Light on, please.
Pazopanib, so there's one case for pazopanib, so only one? Nobody else will treat? Okay, sunitinib? Okay, good. So some for sunitinib. Okay. And everolimus? Would anybody use everolimus? mTOR inhibitor in first line? Yeah, it should not be used. It's not the risk factor. It's a good risk patient. So basically, it's between pazopanib and sunitinib, and which is a reasonable choice, basically. That is what I did. So I used pazopanib in that patient, and this is the total duration of treatment, which is about 2 years. And he had a very good. He had a very good tolerability. Basically, he had some hypertension. And he achieved the minor response as best response. So it also puts into perspective how much response do you need to have a very good outcome. He had then a small CNS lesion, basically, in his course of treatment, which we then treated locally basically. At that point, I continued bisabolid. For me, a CNS lesion is not a point where I would stop medical treatment or switch to another treatment. But during the follow-up, during the successive months, he experienced progressive disease in his bone lesions, basically, which you see here on the bone skeleton. So at that time, based on the negative prognostic factor of bone metastasis, we really discussed how to succeed with that patient. So it's now time to discuss second-line treatment. So it is 2 years down the road. Patient received a TPI for 2 years, and then he had in between some local treatment for CNS metastasis. So what is your choice in second line? Is it now sunitinib? Who would be voting? Please lift up your hands. Using sunitinib as second line?
Would you please keep the light on, please?
Yeah. Or would you use everolimus second line? So okay, so a bigger vote for everolimus actually. Or is there another choice that you may use in your country? I don't know. In mine there would be some, but even though it's not supported. Anyhow, so we will come back to the case later. I will show you now the guidelines that we have in Germany. So the pink thing on your left is the German guideline, and I listed also the EAU guidelines. So we have like multiple options that we try to put into perspective. So based on previous treatment, we have a preference for some treatment options here in Germany. After VEGF failure, everolimus is our recommendation. After failure of sunitinib, it's axitinib or everolimus. So basically what you've seen here, bisabolid prior treatment, that would leave us with everolimus as your prime choice in second line. EAU is a little bit different, and they have a different attitude towards second line, and they will give you axitinib for any VEGF pre-treated patient, which is a little bit interesting because it is not according to the label in Europe. So that is why we basically stick in these scenarios once we have patients failing on bisabolid to everolimus. And something that is quite uniform across our guidelines is that sequencing is really the key. You should sequence your patients among as many drugs as possible. This is also what is written here, because we don't have a German, English translation of the German guidelines, but it's very uniform basically, because we think it derives benefit. And these are your options in terms of progression-free survival curves. So axitinib is an option in principle, and it depicts here the difference between sorafenib and axitinib. This is record one, so this is everolimus, this is placebo, clearly being superior, and this is temsirolimus and sorafenib in second line. They are all options in terms of things that you may use. For record, or for everolimus, it has been argued that record 1 is a mixture of different lines of therapies, and that is why record 4 has been embarked. And this is a pure second line study where patients, after failure of multiple type of therapies, were able to be enrolled, and you see that it really has an impact on progression-free survival. So it's 7.8 months compared to 4.9 in the pivotal study. And if you look for overall survival, it's even more important. Okay, so these are patients with cytokines pre-treated. They're always the best in any kind of analysis. This is sunitinib pre-treatment, and this is any other VEGF inhibitor. So depending on how you select your patients, it will give you a different outcome. I think that's what it says. And it is really important. That is why cross-trial comparison is so difficult and should not be done. So this is what I did with my patient. You see here 2 months of exposure with everolimus. There has been tumor growth in all sites. I marked it here in red, also up here, and this lesion in the mesenterium also became larger. But basically, I think more importantly, it really has been a drug that caused some metabolic effects, and that's something, if you keep in mind, what's the patient profile. It's a cardiovascular disease patient with diabetes and some late-stage side effects or long-term side effects of diabetes, basically. So therefore, he really had problems with hyperglycemia quite a bit. It was very hard to control him. I mean, there wasn't any control of the whole. So that is why we changed after 2 months of exposure of everolimus to third-line treatment. And something that really is important is not only looking at the curves and look for your, baseline parameters, which are basically disease-specific factors, but also look into comorbidities for your patients and how that is being placed into that specific type of therapy, as it has been here for metabolic complications. And when you look into the data for phase 3 studies that are available in second line, you see that there is I would call it modest activity. Okay, so whatever you take, it is about 4 to 5 months range in progression-free survival with any given agent, and there's certainly in terms of overall response rate, which is basically less than 10%, is not what we would like it to be. But there are certain differences in terms of side effects, with diarrhea, for instance, because I think it's a major threat to patients who are on long-term tyrosine kinase inhibitors. This is really a problem for these patients. And it differs between mTOR inhibitors and TKIs. So with TKIs, you will have a lot of mucocutaneous and GI toxicity. With TKIs, with mTOR inhibitors, it is metabolic problems, basically, these pneumonitis infections. And I think record 3 also looked more into detail into that sequencing issue, and it had the exercise to look into whether everolimus is a good option for first line. And the reason why that has been designed is because of the better tolerability profile of everolimus compared to sunitinib, and because the initial study suggested that in terms of progression-free survival, it is really in the range of sunitinib. In here, it's a sequential study, so whoever started off with everolimus changed into sunitinib and vice versa. And basically, at the end of the day, this is a negative study because everolimus was not in the range of equivalence for sunitinib efficacy. But something that it showed nicely is that the sequence of sunitinib followed by everolimus, which is the blue line, is superior to those that started off with everolimus followed by sunitinib. So for me, it really builds the foundation. And in first line, there's no role of an mTOR inhibitor, and the first line treatment should be a tyrosine kinase inhibitor based. So with that, I give you another example. That's the second case. So 45-year-old male patient. He's running his own business, basically. After a long period of time, after 10 years, he had a local recurrence and liver metastasis, and achieved an intermediate score in terms of risk management. He has been treated locally with sunitinib, has been then offered after 6 months of treatment. When the treatment failed, exitinib for again 3 months, and there wasn't any response at that time point. He was sick when he came to my place, B symptoms, weight loss, fatigue, night sweats, and he had a heavy tumor load. So the question is, what to offer here for the patient. And something which I always have in mind for my patient is really, we don't have biomarkers that predict outcome, but something we know is that in the in vivo testing for VEGF insensitivity will give you a different prognostication. And what you see here in red are patients that have a progression-free survival of at least 6 months. Those patients are better off. You will have multiple options for those patients, but for those that have a PFS of less than 6 months, this is still an outcome which is inferior to what we would like it to be, and it's 1/3 of your patients. So it's not a tiny fraction; it's 1/3. So this patient are offered to be treated with everolimus, and what you see here is basically a heavy tumor load in the liver, local recurrences, and this is 1 year later, in September this year, still being on study, as having very good tolerability, excellent in terms of tolerance and very good control of the tumor and also the B symptoms. So he's still running his business basically. And I think that really brings you to the point that where you see that second-line options and sequencing is really important. It's very tough to show this, so this is a small study from ECHO trying to address this question. So here, the blue line are patients that have been exposed with a second-line treatment, basically, and of course they're better off than those that have only first-line treatment. But the real exercise has been that we can identify patients that have predictive biomarkers or predictive parameters at baseline who would not make it to second line, because maybe for those patients we would have a different approach. And the answer is there are no predictive parameters to predict this. And looking into those correlations between response in first line, response in second line, there's also no data suggesting that it is correlated. Progression-free survival or objective response rates have been encouraged and illustrated, and there's no real correlation between first line response and second line response, which makes it very difficult to judge how to select your best treatment choice in second line. And something that has come to our mind with the advent of immunotherapies is the long-term remission. And I put for you data that was available for any given drug and long-term remission. So you see here first and second line approaches, classical target agents, novel target agents, and nivolumab as the immunotherapy agent. You see that the type of response rate really varies, but for those that have achieved the response, the duration of response is pretty similar. It's about 1 year in median, basically, in all these studies. So it really tells you that, even though, immunotherapy is a really important tool in oncology, that you also have patients that derive excellent benefit from target agents or other agents that can be also long-term overall. And something that I think is also of interest is if you look into the outcome of different trials during the past 10 years, starting off with REGOR-1, which is the first trial for refractory patients. We had 14 to 15 months in overall survival, and look at this. This is Checkmate 025, our recent study in second and third line. It adds up to 19.6 months overall survival in median for everolimus, which is the standard arm without crossover. So it tells you that over time, what we have accomplished and what we see in first line, the migration from really 2 years to 30 months and median overall survival is also true in second line, because we see a migration in survival expectations. And the new outlier really is the immunotherapy guide. It's nivolumab with 25 months in the second line scenario. That will give us hope for the next round of novel therapies, actually. And this is what has been presented in September in Vienna for about nivolumab or cabozantinib in 2 large-scale trials with similar patient selection criteria, which is second or third line treatment with up to 2 different tyrosine kinase inhibitors. What it shows you is that we can do trials basically where overall survival is the major endpoint, the primary endpoint. So this is nivolumab treatment. This is the progression-free survival overall, comparing everolimus and nivolumab, showing you that there's some tail at the curve. But more importantly, it really translated to benefit in terms of overall survival in the range of 0.73, the hazard ratio, which is in the range where it becomes clinical relevant, basically. And the same is true for the use of cabozantinib. So if you would have asked me earlier this year, is there a role of a better TKI, I would have said no. We've done this for years and we haven't found any. I think the only guy on the planet who believed this would be a positive study is Tony Cherari. And guess what? He was right. So we see here actually that there's an improvement in progression-free survival in later lines of therapy, and the median overall survival, progression-free survival, 7.4 months, is really novel to the field of previously treated patients. And also, it is one of the few studies where you see a separation of the curves, even though it's not being significant yet. It is only interim analysis, so it's too early to tell. So here again, we might see clinical benefit that will translate into overall survival benefit with the use of cabozantinib, which is somewhat unique to the scenario. And that is what we talk about actually. So when we talk about immunotherapies, it's the tail of the curve. This is data from ipilimumab from melanoma. It really started many years ago when the initial study has been proposed, and that has been followed up since then. And this is more than 4,000 patients. Okay, so you will have a plateau for melanoma, which is about 20% really derived extensive benefit, but there's still 80% missing. Okay, we want it to be 100% if you're very optimistic. How does it look like in renal, basically? So, what is the role of PD-1 ligand expression? And there's data that is, again, 11 years old. It's very old data. For patients that have localized disease, and looking into PD-L1 expression, it will tell you those patients that have PD-L1 expression are poorly off with resection only. So they have a high failure rate, whereas those that are PD-L1 negative really have a better outcome. So there seems to be some association in the local stage between PD-L1 expression and outcome. Nowadays we do have more data for the metastatic disease setting, and PD-L1 expression is again being a negative predictor. So this is COMPARS data, sunitinib and pazopanib, and these are the ones that are being PD-L1 negative, and those two curves are for the PD-L1 positive patients. So giving you the idea that outcome is worse with PD-L1 expression in the metastatic setting, but it also tells you by the steps of the curves that it's only about 15% in total in your metastatic patient population. It's not as high as we would wish it to be. And in a multivariate setting, PD-L1 expression has a more almost similar meaning to prognosis as Karnofsky performance status or organs that have been involved by metastatic disease basically. So within that range of these parameters. So looking into different tumors, you will see that there is about a fraction of patients, which is about 25%, that are being positive for PD-L1 expression, and it varies between lung, renal, melanoma, bladder, head and neck. And it also varies on how you assess. Is it the immune cell you look for? Is it the tumor cell you're looking for? You know that debate is going on. What's the best assessment on PD-L1 positivity? There's no current solution for now, and every single company develops companion diagnostics and claims their test is the best, of course, for that purpose. We will see. It's too early to tell for now. I don't think it will be one single marker. I don't think it will be PD-L1 expression per se. How do we use that in clinic? And I think the melanoma guys are those that are really advanced. They had most experience over the past years with immunotherapies, and something that they embarked on is a journey where they combined immunotherapies, so using CTLA-4 inhibition plus PD-1 inhibition in melanoma. And it has been in the plenary session at ASCO this year, and what you see is that basically there's a net gain from the combination, but if you look into the subgroups, those that are PD-L1 positive are those that do not benefit from the combination, whereas if you look for the PD-L1 negatives, there is a benefit for efficacy if you combine CTLA-4 and PD-1 inhibition. And I think this is where we are right now, and how we try to individualize our treatment. It could be done on PD-L1 for the combination with a single agent, but it's probably not sufficient to be the only marker.
So we are running out of time, so
are we?
You have a 2 session, so
okay.
10 minutes left. Yeah.
Okay, we've got still 8 minutes. Okay. So basically, I mean, the question is, are there other markers? And there is genetic instability as a predictor of outcome. It works fine in melanoma and colorectal, as you see here. And if the tumor is genetically unstable, it will give you better readout. And that's the story of neoantigens, basically. So if the tumor produces mutations, and they will produce novel proteins that are unknown to your immune system, and therefore these tumors seem to be more immune responsive. That's kind of the hypothesis. And their study suggesting this, but it's becoming more critical. It has been the first study suggesting it, but it's now coming more data out. It seems to be more controversial, basically, and that's something I think that it's one of the last slides that I would like to share with you. So basically, I mean, it's a cartoon that I drew myself. So basically, we have inflammatory tumors and non-inflammatory tumors. Whatever is blue are the T cells or immune cells, and tumors that are have T cells inside, those are the ones that we're currently targeting already. So they are fine. These are the PD-L1 positive tumors. Okay, you can target by single agent checkpoint inhibition. For those tumors that are innate, they don't have an immune response. We have to find a way on how to boost immune response, how to prime the T cells actually to go to the tumor and then start acting as a T cell. So for that purpose, we will have to do combinations basically. And that's where we are right now and how we set up our studies in order to derive the maximum benefit out of that combination approach in RCC. And it's not the end of the story basically, because here is what you see is that's what we target right now, and that's what I highlighted here in blue, and there's more to come. So they are TIM-3, LEC-3, there's CD137, GITR, OX40, CD28. These are all molecules of checkpoint inhibitors that are coming to the clinic and are in current clinical development. So with that, I would like to close actually, and I'm ready to take questions.
Thank you, Dr. Grunwald. The session is open for questions for both RCC and immunotherapy. Microphone.
Thank you, sir, for this comprehensive talk. I wonder if the trial of the last trial in Vienna, where the isoclip is versus Aurorus in the second and third line, you find that the progression-free survival not affected and the overall survival is affected. Can you elaborate on that?
I think it's a novel concept that we have to somehow adapt to, because we have been trained for decades that we look for response, and response will give us benefit, clinical benefit, and we look for time to event curves, which is progression-free survival, for instance. And it may not work for immunotherapies. I think that's the bottom line. And I think it has been very hard to swallow, because we have been all raised with chemotherapy, and there's a clear dose and response relationship and outcome. And it is different for immunotherapies, and there's some change in the microenvironment and the constant immune response over time. It will give you some benefit in overall survival.
Means that the immune response is take time to get action, or it augment in time?
So the question is, why don't we see, I mean, progression-free survival benefit is less than what we see in overall survival. Yes, it is true. You know, there are effects that you may not capture by looking for progression-free survival, for instance. And there are various reasons why you drop off from a certain treatment. Treatment beyond of progression is a big issue. So there has been data from nivolumab studies that have shown that if you treat a patient who has been progressing per RECIST-defined parameters, it will give you better outcome, basically. So they compared that to the conventional or to the whole group of patients, and OS has been dramatically improved by doing that. So I think there's much to learn on how to best deliver these kind of agents. And there's no clear answer actually why. There's no clear view on which patient or population of the T lymphocytes, or maybe it's the whole set, the network of immune cells that is being influenced. What about macrophages? You know, what about NK cells? We don't know that actually. It's about to start. I think it really is. We start at zero basically. You know, we don't know much on how that really influences the outcome. Thing is, I mean, it's OS. That's what it comes out to be, and it's a solid marker. I think it's good that we really skip the progression-free survival talk that we have. and it comes down to overall survival, which is very good to our patients.
Yes, Dr. Ahmed.
Thank you very much for this nice overview. So the title is the sequence is the issue. So for our patients, we'll start, for example, in the good and moderate risk, we'll start with TKI, then M2. What's next? We start with cabozantinib or with immunotherapy. And is this different in the poor risk groups or this?
So basically, I think whatever you have available, you should use in your patients. So if you're restricted for some certain reimbursement issue, then you do whatever you can is best for your patient. I think it's the most important part is staying on therapy for the patients. That's what we see with the migration of the overall survival curves. So I tend to use M2 inhibitors in second line, not exclusively, but I use them often because of the break that they give the patients in terms of tolerability and toxicity. And there's studies suggesting, so if you, let's say you do TKI, you do an M2 inhibitor, there's data to suggest that sorafenib should be next in line, which is third line, based on the gold study results. And that is what I do, basically. That is what I do in third line. What will I do next year? That was the question too. Will I use nivolumab in second line? Yes, I will. It's overall survival. It's, the benefit. We're not talking about a couple of weeks of benefit. It is OS that we deliver, and it's one of the few studies that really is able to do that. And it's a decently sized study with more than 1,000 patients. Of course, I will. And as you have seen the progression-free survival curve, most of your patients, or half of your patients, are out of treatment with the first scan after 3 months. So for them, you will have to offer another round of therapy, and we have to see how that really comes down to it. We use TKI or M2 inhibitors or whatever. So I think from record 3, we've learned that there's subgroups of patients that have benefit from everolimus that comes within the range of sunitinib. So we really have to do more work on that to come down with the predictive markers to suggest what is the best sequence for a given patient and not following A, B, C, D, E on a strict line.
Thank you, Dr. Becker, for your excellent presentation. So I think before we close the session, I think you finished the second lecture, is that no?
There's no
you combined both lectures?
I combined both.
Yeah, okay. Before we close the session, we would like to thank all the guest speakers as well as the organizing committee and all of you. Thank you very much. We close the session.